So welcome to the Understanding Partial Dentures, Classification, Design, and Materials. It is being presented by Tremaine Watkins, CDT, and we're going to begin shortly. And with that, it is my pleasure to introduce Tremaine Watkins, CDT, Director of Strategic Education. Tremaine Watkins has been working in the dental laboratory industry for more than 30 years. After graduating with a Bachelor of Arts from Trinity College in Issaquah, Washington, a class valedictorian, he has gained extensive experience in all aspects of fixed and removable restorations, with an emphasis on implant-supported and retained restorations. He also has provided clinical support in case planning, troubleshooting, and implant placement. He has trained other technicians in all aspects of dental technology and has written and lectured on several aspects in restorative dentistry. And now it is my pleasure to say, take it away, Tremaine.
Thank you very much, Jessica. For you guys that just see Jessica as like a couple minutes at the beginning, like I'm the hired gun. I come in and do my little part, but everything else that happens is Jessica and Glenn as well in this situation. So thank you very much for all your hard work you do, Jessica. You are behind the scenes, but boy, it's important. All right. Well, tonight we're going to talk about partial dentures, and I was like, well, sometimes some of our older removable topics, they're not as, I don't know, sexy as some of the implant things and stuff like that. But at the end of the day, we're doing lots of partials all the time. And I think that I was just reading an article today that was talking about how partial technicians are retiring. So I think one of the challenges, and especially as we see more CAD CAM, so if I don't know how to pour a duplicate properly or to do a survey, like I can't make an old school analog partial frame. It's just not possible. But with modern CAD CAM technology, I can just draw lines on the screen and come up with whatever. So I think that in some ways it's good because it makes the technology more accessible and more likely that you guys are able to get the partials you need. But sometimes it helps people do the partials that may not understand exactly what they're doing. So I think as clinicians, it's good for you to have a better understanding of this so that you can kind of mentor your technicians and make sure you get the best results that you can. One of the fun things about partials is that there's usually more than one way to do a case, and we can kind of challenge ourselves to come up with the most stable and simple and hygienic solution for a given case. So tonight we're going to talk about a lot of the rules we're going to talk about kind of are based on a metal frame partial, but you'll see how that applies to different like flexibles and stuff like that. And we'll talk about a new flexible product that just came out at Lab Day this year. So you want to talk about an evolving field, doesn't get much more than that. So anyhow, there's the intro. So I'm an employee of National Dentex. I'm paid by my company to do this presentation, but other than that, there's no financial support for this program. So the first thing I want to do is really give a shout out to these two resources. I read through these. So much of what I know about partial dentures is anecdotal, and so it was very helpful to have some nice academic resources to kind of pull everything together. So anything that's not quite right is on me, but anything that's awesome came from these guys. So here we go. So we're going to be talking about, I should have changed this to 2025. We're going to be talking about partial dentures tonight. Of course, we talked theory and practical clinical use. And you're probably asking, why in the world are we even talking about partials? In almost every situation that we're dealing with, we could place an implant. We know that implants are probably the next best thing to natural teeth, and they become predictable. There's lots of great ways to add bone and tissue if those are challenges. But not everybody is going to be a candidate for an implant. Sometimes people are, their health just isn't there. Sometimes financially they don't want to make the investment. So you're still going to find, I'm sure you all find situations where you're doing partial dentures. The other thing to keep in mind is that partial dentures are often a great solution for the provisional for an implant. So So I think that there's still merit in understanding partial dentures, even though we can, we can place implants. I have some other presentations on implants, so I don't want to beat that too much, but I do feel like this kind of brings out one of the things that you'll find when you hear me talk is that I like to talk a lot about patient communication, because I think that having good communication with our patients is the key really to successful dental treatments. And I think this is an example of value, is that when you're presenting the options to your patients, you want to make sure you know what all the options are, but then you want to make sure that you can kind of do a good, better, best presentation for them so that they understand, this option may be a little more affordable, but there are certain drawbacks to it. This option may be a little more expensive, but there are some long-term and short-term benefits. So I think challenge yourself to be able to present all the options that are out there in a way that's congruent. You know what I mean? So the patient can see this is more expensive, it's more valuable, this is a little less expensive, it might not have quite as much value. So we'll start out with, like we always do with partials, with the Kennedy classes. So these were developed in 1923 and updated by Dr. Applegate in 1954. And you can see that we have four basic, I'm sure you learned in school, four basic classes of partials. So class one has bilateral free ends. These partials are mostly tissue-borne, and so they're gonna be mobile. So one of the things that we have to think about with these, well, two things. One is when we're talking to our patients, we need to let them know these are going to move. When you bite on it, it's going to move. And then when we're designing it, we need to use, and we'll talk about RPIs specifically, we need to use the right kind of clasping so that we're not torquing those premolars in this case and potentially messing them up. Now, Kennedy class 2, going to have some movement. We can usually tack it down with a really nice, like a double acres or something like that on the contralateral side from the saddle, but these have an axis of rotation. So one of the things we need to do is make sure that we'll use indirect retainers to make sure that we control at least the lifting of these prosthetics. Class 3, these we should be able to get them pretty darn stable. So unless we're doing a Nesbitt or something like that, these cases should be very, very stable. We want to challenge ourselves to get our patients that have a posterior abutment a very, very sturdy solution. And then class 4, depends on how big the space is, we can usually get them pretty stable. The problem with these is cosmetics. And so we need to make sure we have the right combination of clasp design and materials to get the patient good aesthetics. Also, one of my favorite sayings is under promise and over deliver. So make sure that your patients are expecting less aesthetics than you're pretty sure you can deliver for the class 4. Again, these are cases where we could, like this case, we could place a couple implants and do a nice little bridge. So there are other solutions. So if your patient says, well, I don't even want clear clasp, let alone metal clasp, you can say, great, let me talk to you about a fixed solution. So anyhow, I think I'll quit beating on that. So these are Applegate's rules, and basically they were added to kind of help define, make sure we put cases in the right Kennedy classification. And again, not so that we can win at dental trivial pursuits, but so that we can adopt an appropriate partial design strategy to get the best result for our patients. So we want to make sure, of course, that the case is stable. So we're not going to evaluate the case until any necessary extractions are going to be done. And then for posterior saddles or potential saddles, if we're not putting teeth there, they don't count. So in other words, we'll see on the next slide, we're not going to restore the second molar on the patient's right. So therefore, it wouldn't count. However, if we are using the third molars as abutments, then we do count those. Rule number 5 is pretty important because you guys have, I'm sure, seen lots of cases where you have a couple of premolars and a cuspid, and again, we'll see that on the next slide. And it's like, well, what is it? Is it a class 1 or a class 4? And so in those situations, we can talk about that the most posterior dentulous region determines it. So you'll see this case is a class 1 with an anterior modification space, which is our 6th rule. And the modification space doesn't really matter how big it is, it just matters that it exists. And so obviously class 4 wouldn't have a modification space, because if it did, it would be something posterior that would then change the nature of the case. So let's use the rules and look at this case for a minute. So I referenced both of these just a minute ago, but if you look at the maxillary case, let's say we're not going to replace number 2. So all of a sudden, this isn't a saddle, and this becomes a class 2 case. And then this is the case we were talking about, where it does have an anterior space, but it also has 2 free end saddles. So this becomes a class 1 with an anterior modification, not a class 4 case. So again, why do we care? Not because we're trying to win at Trivial Pursuits, but because, for instance, if this were a class 4, we would be telling ourselves and our patient, yeah, we can get that pretty stable. But knowing that it's a class 1, we know we're going to have a little bit of movement. And so we're adopting an entirely different strategy. And as with this one, if it was a class, we would have an axis of rotation, but it wouldn't be as pronounced. But as a class 2 case, we're going to, oh, I have class 1 up here, but I'm pretending like I'm not replacing this tooth. We only have 1 saddle. So let's talk about the different parts of a partial denture. And even if you're doing a flexible or something like that, we're still going to have all these parts, and we kind of need to talk about and design each one. So the major connector, of course, is this part. This is the part that connects all the other parts of the partial. It needs to be rigid, and it needs to be, we need to leave the mouth as open as possible, especially on the maxilla. And we'll kind of talk about how we design these for optimal hygiene, and also so that we're not abusing the tissue right at the free gingival tissue there. Minor connectors then connect to the clasp assemblies and rests and things like that. And a lot of times minor connectors, we treat them like they're just along for the ride, but they can be a really important source of stability if we turn them into a guide plane or something like that. One of the things I think that we want to do with our partials is we want to kind of challenge ourselves to make some of the parts serve double duty to make the case more stable without being more complex and difficult to clean. Direct retainers are our clasps, of course, and they're kind of what make a partial work. Indirect retainers are things like our rest here on D that, you know, with our, what am I trying to say? With our axis of rotation here, this prevents the saddle from flipping up. And then, of course, our denture base. And that's the point of the whole thing, is the teeth that we're replacing. We also want to, especially for our class 1 and 2 cases, we want to make sure we have a nice large pad on our posterior area so that we're spreading the load over a large area, and we're helping to make that as stable as possible. Because again, the denture base is the only thing that's going to resist depression. So let's talk about how we can design partials. We can do an analog process or a digital process. So I use the left-hand image as kind of a shorthand for the analog process. For those of you that know how to do it, it's a good process. It's been around for a long time. It uses fairly simple equipment, but it's very, very technique sensitive. And there's a couple stages when you're manufacturing the partial where, you know, your ring can blow up, or your refractory model can degenerate, and all of a sudden you have a frame that's not very usable. So relatively recently, we've developed the ability to digitally manufacture our partials. And because of that, now we have a digital design process. So when we're talking about this, we'll continue to kind of talk about partials from an analog perspective, and then I'll kind of talk about how we use digital with that, because you'll find that the digital processes are kind of built on the analog way, so that way when technicians are making the transition, they're like, okay, well, I know how to do a survey in the analog world, so now I just translate those skills over to digital. It took a long time for us labs to digitize on the crown and bridge side of things. I think about from the first time that I heard about a milling machine to now everybody has one. It was a long time. But I think we're seeing that now there's kind of an enthusiasm for digital. And so what we're seeing on the removable side is that the rate of adoption is much faster. And these days it's more like people are like, let's do it. How come we can't do it? And the materials and the equipment are trying to catch up. Partial frames are kind of a good example of this. The equipment to most people who do them do laser printing. You could mill them, but it's expensive and time consuming to actually run the mill. With laser melting, the equipment is expensive, but you can make quite a few frames at the same time. I was thinking of one lab I was in particular where one of the technicians there, she'd been doing partials her whole life, and she was saying how much she enjoys the predictability of digital partials. It's like, well, I do my survey, do my design, I print it, comes out every single time. If I do the steps properly, it comes out good. As opposed to with the analog process where I did all the steps, but I get something that's unusable and I get to do it again, which is not so cool. So the first step in designing a partial is doing the survey process. Again, we'll talk about the analog survey first, and then we'll talk about what that looks like in digital. So as you guys know, you can think of a partial as a bridge that fits on all the teeth. So needless to say, with most teeth, there's quite a lot of undercuts that we need to block out. One of the things that took me a while to figure out on this, I'm sure you guys have probably already thought of this, is that I can't just set the path of insertion any old way to get to make the undercuts work better. Wherever I set the path of insertion, that's the direction that the patient will actually be taking the partial in and out several times per day. So in general, I want the plane of occlusion flat on the surveyor relative to the bench, or as with this, I want to have the anterior a little bit higher. We want to be careful not to raise the posterior higher, because that path of insertion is going to be very, very difficult for the patient to use. The reason we do the survey is so that we can mark the height of contour, as you see on the right-hand side here, and then block out all those undercuts other than the ones that we need for the clasp. So this is very time-consuming. When you're doing analog, you got to mark this, wax it, go through with a surveying tool and smooth everything out, and then gently carve little areas. When you're doing this digitally, you turn the model until you like the view, you push basically the block out button, it blocks it out, and then you just digitally remove any block out you don't want. If you don't like the survey, you don't have to redo the whole thing. Just turn it and click it again. So this is an area where it saves us a ton of time. And not only that, but then you don't have to make your refractory duplicate. So, so this is a step where digital is very helpful in terms of predictability and time usage. So how do we decide what a good partial looks like? Like, how are we going to look at these cases and say, oh, this one's pretty good and this one not so much? So we have these 5 criteria that we want to look at. Our first is retention. There's a balance. We definitely want our partial to be solid when it's seated, especially like this case where we have posterior abutments. This should be very, very stable when it's down. But on the other hand, we don't want it so retentive that the patient can't take it in and out. So we need to find that balance. With most of the cases that we're dealing with, this is probably one of the easiest to achieve. Stability, and like we talked about, stability is going to depend on the classification of the case. For some cases, we want to manage the instability, minimize the instability. For others, we're able to get the partial fully stable. Again, patient communication, we want to make sure that we explain how stable we can make it and what the results are. Support, there's two sides to support as well. So one side is that we need to choose the teeth that will be supporting the partial well, so that the extra load that we're putting on them doesn't cause them to fail prematurely, and also that we're preparing the tooth properly to support the partial in terms of rests, occlusal clearance, that sort of thing. But we also want to think about the other side of support. Many times we're making saddles that need to support the cheeks or the lips. So we want to make sure we get our teeth in the right position. Again, we want to look at the case and know what the best result we can achieve. And if we look at it and we say, this is not as good as somebody might like, we want to make sure we have good, clear communication about that. Comfort. If we get the first three, we're probably well on our way to comfort. From that point, the main thing is basically on us in the laboratory. We need to make sure that the prosthetic is smooth and it's well adapted to the model. The borders are nice. And as long as we don't have it pressing on it, a sensitive anatomic area like tori or the incisive papilla or interfering with the frena or something like that, we'll usually have a good result. And I would say, on the other hand, aesthetics are probably the biggest challenge with partial dentures. It's not just the clasping. A lot of times, oops, let me go back here for a minute. I was trying to point to this. This finish line can be visible in the mouth. And so we want to kind of talk to our patients about that and make sure they understand any aesthetic limitations, especially if we're building saddles in the anterior region. That can be really important. We also want to make sure that when we're doing, we're picking our materials like our clear clasp or something like that, that we're picking materials that are as aesthetic as possible. Again, under promise, over deliver. We want to make sure that our patients are always surprised by how nice the case comes out. So now we're looking at partial design. What are some basic rules that we want to talk about? We've kind of alluded to this a couple times, but less is more. If I can get a good result with 3 clasps or a good result with 4 clasps, I should use the 3 clasps because that gives less areas for trapping food, less things to break. A simpler case is a better case. We want to make sure that we have really good base adaptation. As you guys know, patients are going to have resorption, and the worse the fit and the movement, the more resorption we're going to see. So we want to make sure that we do a good job with that. Use what's present. If I have space for a rest in one area and I have to cut a big old rest in another one, I may want to use the space that I already have on the occlusion as opposed to having to do invasive preparations. So kind of when you start working on a plan for a partial case, be thinking about what's the least invasive way I can do this. Plan for the future. There's several aspects of this. One is, am I using a material that I can add to if I see some teeth? The most common example I see of this is a case that has, say it's a class 1 on the mandible, and there's several mobile teeth in the anterior region. A lot of times what we'll do with that is we'll do a metal frame partial, and then we'll do a lingual plate, even if we don't necessarily need it, because it gives us a surface that we can weld some lugs to and add teeth. So kind of be thinking about what teeth are likely to be lost, and is there a way to incorporate them into our existing partial. We don't want to put occlusion on the rests. And then we want to we talk about group function excursions. We want to make sure that as our patients are functioning on our partials, we're not adding a whole bunch of tipping force that is going to tend to cause our partial to be dislodged. It's easier to manage on the partial side than it is on the denture side. I was talking about dentures this morning, actually. But we just want to make sure that our occlusion is contributing to our stability in our case. So now let's talk about the different elements of our partials. So we either want to be apical to the free gingival margins, 3 millimeters, or we want to use a plate. We don't really want to design our lingual bars or the anterior aspect of our palatal metal or palatal framework right up against the tissue, so that way we're not hammering on that fragile tissue there. We talked about using our lingual plates if we expect to lose anterior teeth. And again, metal partials are a good solution for that because it's fairly easy to weld a lug on there and then add a tooth. And then on the maxilla, we kind of have two ends of the spectrum. On the one side, we need to make sure that we have enough palatal coverage so that the partial is stable. It's not going to be a comfortable, good-fitting, sturdy partial if the major connector is flexing. On the other hand, the more we can uncover the palate, the better taste sensation our patients are going to have, and the more they're going to like their partial. So we want to do an AP strap like this as much as we can, as opposed to full palatal coverage. We only really want to use full palatal coverage when we have 5 or less anterior teeth and we really need a sturdy frame. So we'll talk about our retentive grid. In the maxilla, we want to bring our grid over the tuberosities. We want to end before the retromolar pad on the mandible, and then tissue stops. Now, these aren't as essential with like the quick snap, the new digital manufacturing processes, but when we're injecting or packing, we're going to put a lot of force on this frame when we pack the resin in here, and as it squirts through the grid work. So the reason we put those little pads back here is so that when we put that force on it, they hold the grid work off the model, so that way we can get resin on the underside as well. So any of these frames that are going to have potential movement, we want to make sure that we have those nice tissue stops. Guide planes. These are really important, and I think there's something that's kind of overlooked in partial design. A lot of times we think, well, the only way I can get retention on a partial is with clasps. But if we can do something like this where we have guide planes that oppose each other, this isn't going to cause the partial to snap in, but it's going to make it very, very stable, and it's going to make the clasps more effective. So whenever you see an opportunity to use guide planes, I would take advantage of it, especially if you don't have to do a lot of preparation, if the teeth kind of naturally have these guide planes. This is an area where you can kind of put your minor connectors to work. So in other words, let's say that our premolar here had a distal rest, or our molar had a mesial rest. We could turn the minor connector into a guide plane, and then we might find that just putting one clasp on this molar, we might be able to avoid clasping the premolar altogether, utilizing the stability from this. Again, as the picture is showing here, these are most effective if they're close to each other and they directly oppose each other like this. If you have one on one side of the arch, one on the other side of the arch, it's not going to be as effective. Again, we can't do it on every case, but I do think it's an overlooked potential source of stability for our cases. So our rests. We need to make sure we look at our occlusal clearance with all rests. This is something that I think us labs didn't do such a great job on in the past. Because we would wax these on a refractory model, it was difficult to articulate. Sometimes we just be like, okay, well, I'm going to put the rests on, and then you as a clinician have to do whatever you got to do to get the occlusion to close. Not so awesome. Definitely an area where we can do a better job with the digital processes that we do now, but we need to make sure that we have a good shape for our rests. We want to make sure that we, of course, we want to use cingulum rests on the canines. Some people like to do incisal rests on the incisors, but in general, we want to avoid that. And if we have an amalgam, the force from the rest is probably going to lead to damage long term. So it's probably better to avoid putting rests on our amalgams. One other thing I would say that's not on here is when you're designing your rest, it's best to do kind of a rounded shape, because as you know, stress tends to focus at sharp corners. So when we cut more of a boxing, we're just adding points where there could be potential failure. Good direct retainer. I have seen a lot of bad direct retainers in my life, I'll say that. So these are so important. And there's several different components to it. So obviously the support in this case is an anchor's clasp, as you know, is going to come from the rest. So depending on the type of clasp and the type of partial, we may or may not be able to incorporate this. So for instance, a flexible isn't going to have one of these. But in general, it's nice to have a stop built right there into the clasp assembly. Reciprocity is really, really important. Sometimes, again, and this is more on slabs, but kind of keep an eye on this yourself. Sometimes we make both sides of this retentive, whereas in truth, this arm needs to sit above the height of contour, so it's just sitting there passively. And then that allows this retentive tip to do all the work. If you're dealing with a case that tends to be springy and you feel like you've adjusted the clasp, double check the reciprocating arm, because maybe it was designed to be retentive. It shouldn't be, but that happens sometimes. Of course, we want the case to be stable. Retention and encirclement kind of go together. Sometimes you'll see clasps that, for whatever reason, don't go past the midline of the tooth. And so as this clasp tip tries to engage the undercut, it causes the partial to want to spring away from the tooth. So we want to make sure we go as far around the tooth as possible, certainly more than 180 degrees. And then last but not least, we want to make sure that when our clasp is fully seated, that it's passive. So of course, it's going to take a little force to get over the height of contour. But once the partial's down, we don't want it to work as an orthodontic device. We want it to just sit there on the rest on the tooth. So in terms of the undercut, and this can have a huge effect on aesthetics, we need a 0.3 of a millimeter undercut for a cast clasp and 0.5 for a Rottweiler. If we're doing flexibles, some of the materials require as much between 0.5 millimeter and 1 millimeter, depending on how thick we make the material. Again, we don't want the bracing arm to be active. We want it to just sit in the above the height of contour. And then we want the clasp. We call this the active tip. We only want this tip to be flexing. We want the rest of this to sit nicely on the tooth and this to engage the undercut. And then, as we were talking about earlier, we want to make sure our partials are as simple as possible. So we shouldn't need more than 4 clasps. If we're coming up with a design with a whole bunch more clasps than that, let's kind of look at it with a bit of a jaundiced eye and say, hey, is there a way that we can simplify this case to make it more hygienic and just less complex for our poor patients? So let's talk about some of the different clasp assemblies that are out there. Acre's probably the most common. It's got everything in one nice package. It's got a bracing arm, it's got a rest, it's got, of course, the active clasp. It's sturdy. The main 2 challenges with this are that One, you need to have some occlusal clearance in this area right here. So sometimes that can be a challenge. And then the second thing is that there's a lot of metal showing, no matter which way you turn it. In this case, you'd have all this metal showing from the mesial, but even if I use a distal rest, which is okay, I'm still going to have the clasp tips coming around. So it's a good utility clasp in the posterior, but we do want to be aware of the aesthetic limitations and plan accordingly. And you think that's big, then we got our double embrasure clasp. These really have a place. So a lot of times with your Kennedy class 2 cases, you're going to need a really sturdy clasp assembly directly opposite your saddle. And this can be a great rest. We need to make sure there's what we sometimes call a pass-through, that there's space between the opposing tooth and the marginal ridges here, and also that we have rests. Usually the undercut isn't as big a deal. We can sometimes do a back action if we don't have a lot of retention on the buccal. There's usually some on the lingual that we can get a hold of. Again, these things are ginormous, so we want to make sure we keep them in the back of the mouth. But they're really, once you have one of these, you pretty much have one side of the whole case kind of tacked down. And now you can just kind of focus on the other side, getting it where it needs to be. Bar clasps, of course, as our patients become more and more concerned about cosmetics, we use more and more of these. Most of the time, we're choosing the shape of the arm based on where our height of contour is. So sometimes like a C or something like that can be nice just because it allows us to keep the tip less visible. These cases, the main challenge with them is when we don't have a deep enough vestibule and they have to emerge from an adjacent saddle, so we can't use them any old place. We'll talk about this in a minute. Oh yeah, that's my next slide, so I'll just save it for that. But the I-bar is a special case of this that I think a lot of us don't use it to our best advantage, let's say that. So a lot of times, and I've seen this, I've done this, need to not do this. When we're dealing with the class 1 and class 2 cases, again, we know that the tissue is going to depress, so we know that the saddle is going to move. And this is, an I-bar is our best solution for these cases. Because we need a mesial rest, a distal guide plane, and then our buccal eye clasp. The reason that we want this design is because when the person bites down, this can move gently, and it doesn't put very much torquing force on the tooth at all. On the other hand, if we do it backwards and we put a distal rest on here, we're putting a lot of torquing force on these cases. So we need to make sure, again, for you guys, make sure that you're using I-bars next to your free end saddles, and then that your laboratory is putting the rest on the mesial, not on the distal. So again, severe undercuts, I didn't mention that before, but and shallow vestibules can be kind of a contraindication for these. So the fulcrum line, when we're working on our cases, we need to think about where's our partial going to rotate and what can we do to fix it. Like for instance, this case, we could use a double acres on here and here, and then not only do we get a ton of retention, especially if we can get like a guide plane or something like that to lock this down, but that's going to pretty much prevent any kind of rotation. Most of the time you'll see we're using an indirect retainer on one of the cuspids with a lot of these. This one we might want to do both cuspids just because we need to brace on both sides. So if we can prevent the fulcrum movement altogether, the rotational movement across the fulcrum altogether, so much the better. If we're going to get some because of depression of the tissue, then we want to make sure we use an indirect retainer. to kind of resist that. So let's talk about when we're planning out these cases, what are kind of some general rules for each one? So for a Kennedy class 1, we want to do, for most of the cases, we're going to want to do a lingual bar on the mandible if we can. It'll be more hygienic and more comfortable for our patients. Again, AP strap for the maxilla, taste sensation and the like. Only use a full palate if we need it. We want to make sure that the denture bases on these are large, because again, most of the stability as the patient bites on the case is going to be from the fit of the saddles. Use our RPI clasp again with our mesial rests to allow that movement without torquing the teeth. Indirect retainers to prevent flipping. And then one of the things we can kind of think about with these cases is, would our patients benefit from a implant under one of the saddles? If we're doing that, we also want to help be thinking all on X. In other words, you're placing an implant anyhow, so make sure you place it deep enough so that there is going to be adequate restorative space for an all on X, and that it's positioned such that you'd get good AP spread and stuff like that. Again, you can't always do that, but if you're placing implants anyhow, and let's say you put 2 in to stabilize a double free end case, well, 2 more, and you can do a screw retained or snap retained restoration for your patient. So kind of beginning with the end in mind can be helpful on these cases. Class 2, again, a lot of things are similar. The main thing is that we need to understand our fulcrum, our axis of rotation, so that way we can get an indirect retainer as far from that as possible to prevent that flipping. Kennedy class 3, if you can get away with it, in anchors on either side of the edentulous area can be very stable, or sometimes you can do an anchors on the distal and a bar clasp on the mesial. And a lot of patients like these. You need to make sure that they don't wear them at night, and that you talk to them about that it's more of a cosmetic restoration than a functional restoration. But for those patients that want something small and relatively inexpensive to fill in a missing tooth space, or even to give a really nice provisional for someone who's having an implant placed, this can be something that we sometimes don't think about. Most labs are fine with doing a 1 or 2 teeth unilateral. Usually we try not to do 3, because at that point they start getting very mobile. Kennedy class 4, again, many things are similar. The one thing we want to look for is, are there ways that we can use a more aesthetic clasping scheme to get a to make the case look nice for our patients? So and think about where our finish lines are. One of the real challenges in the anterior region is if you have 1 tooth left in the middle and you have seams that are very, very visible in the anterior. As you would with an all-on-X case, sometimes it can be helpful to look at these cases, get the patient to do a really big smile for you, and kind of think about, are they going to see those transitions on either side? Because it's important. You guys all know that if we've talked with our patient ahead of time and we've told them there are some potential negative consequences to a decision that they're making, or we don't say anything and we get the same cosmetic result in both situations. In the first situation, usually the patient's like, oh, okay, well, we talked about it and I chose to do this, so this is kind of on me. And sometimes in the second situation, they're like, well, how come this looks so bad? Blah, 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 blah. So we really want to make sure that we're with our partial patients, and especially with when we're making restorations that are in the anterior region, that we're giving them a good idea of what the aesthetic result is going to be like, so that they're prepared for better or for worse, kind of what they're going to get. So before we start talking about materials, I want to kind of cover tissue or tooth support. The materials that we have, there are a few that are strong enough to make rests. And so for those can be at least partially tooth supported. I would say in general, a tooth supported partial is going to be superior to a tissue supported, because we can somewhat arrest or at least reduce the amount of hard and soft tissue loss that happens over time. So again, if we need to do tissue support, if the patient would prefer tissue support, that's okay. We just need to talk about the potential long-term ramifications of that. And I think we also need to emphasize the importance of relines and different things like that to be able to, because again, the better adaptation we have on our removable prosthetics for that particular patient will be helping them get retain their bone as long as possible. So as we're talking through these different materials, we'll talk about whether they're tissue supported or tooth supported. So here it is, Old Faithful, the chrome cobalt metal frame partial. So a few years ago, the EU passed some regulations that limited the use of cobalt alloys. And so for a while, I remember there's a bit of a tempest in a teapot over, should we be using this and this sort of thing? There was a meta study done in 2022 of 21 in vitro and in vivo studies that showed actually that chrome cobalt, while it's not quite as biocompatible as titanium, it's not that far off, and it's much more compatible than nickel. They also didn't see any cytotoxicity to human cells in the in vitro testing. So this has been a good solution since 1929, and it's still a good solution. All aspects of it can be repaired. The metal can be repaired, the plastic can be repaired, the teeth can be replaced, and we can add to it. Again, talking about beginning with the end in mind, if we know we're going to be losing teeth over time, we can kind of design our partials to be able to add more. These are fairly light, and because the metal is so strong, we can make the frameworks thinner. We can build the retentive aspects and the rigid aspects of the frame out of the same material. So there's a lot good about this. And again, there's a brand new workflow in ExoCAD that allows you to do this all digital. You can design the whole thing, and then you can SLM print the frame and polish it, and then print the saddles and the teeth and snap them together when you do your post-curing. So there is really a nice workflow for doing these in 2025. So I think that sometimes it's like, oh, well, that's such old school, but I mean, it's old school for a reason. It's been around for a long time because it works. So is this the right solution for every patient? No, but I think that sometimes it's easy to overlook this just because it's been around so long. Familiarity breeds contempt, perhaps. But for a lot of patients, just like a gold crown can be a great solution, it has a lot going for it. This is kind of the gold crown of partials, I feel like. All acrylic partials. I mean, how many names are there for this? Treatment partials, temporary partials, flippers, partials that are made all from acrylic. As you can see here, we'll usually embed clasps in them, especially for larger ones. These are kind of our go-to, I know, for immediate extractions, because they're fairly easy to reline or to adjust. But one of the things that we've seen more in the laboratory lately is we're seeing a lot of these being used as long-term partials. And they're not awesome for that because many times the reciprocity from the fit of the plastic is not as good as a cast frame, so you're going to get more mobility. They're more inclined to break. I mean, they're just not as strong as some of the other materials. So they're usually more affordable, which I think is why we're seeing more of these. But we need to, again, make sure that we talk about with our patients about how long can we expect this to last? What kind of restoration is this? Is this a long-term restoration, or is this something that we're going to be just using for a short period of time? And again, I mean, if your patients want to use it longer, that's okay. But if you've told them, hey, it's for 3 months, and then they come back in a year and say, hey, it broke, you're like, hey, oh, well, good. You got 9 extra months out of it. Congratulations. One of the things in general that's good to talk to your laboratory about this is how do they like to make their partials? Are there acrylic partials? There's so many different ways to do acrylic. There's pour technique, which has gotten more popular recently. Of course, there's traditional packing. There's injection. There's and then of course there's 3D printing as well. This is an example where the technology is moving right now. There's a Stratasys has a printer that will now print the teeth and the pink in all one pass. Obviously, it doesn't print the metal clasps, so you got to figure out a way to get those in there. But what we're finding is that the resins that are available aren't quite as sturdy as some of the DLP resins, so they're a little bit more prone to breakage. But I think we'll see, as this technology continues to move, I think we'll see jet printing like that becoming more and more popular, especially because you can print polychromatic teeth, and once the nesting software gets updated, polychromatic bases. So you'd be able to print gingival characterization and all that stuff, because there are a lot of different, there's a variety of different colors, and the printer actually makes the colors that you request by mixing various materials from the jet. Also, that printer uses a support material, so it tends to make things a little more accurate than the fence supports that you're seeing quite a lot. So I don't think we're seeing a lot of printed acrylic partials, but the workflow is there, and I think we'll see more and more of this. Again, I expect to see digital adaptation or digital adoption on the removable side going much faster than it did on the fixed side. Flexible partials. When I made up this presentation, these could only be made analog. So you would set the teeth on a base plate, you guys would try it in, and then we'd process them and inject them. So I have some news from Chicago, but that's the next slide. So a couple things about this. One is that restorative space is really important with these. The retention of the teeth in the analog process flexibles is all mechanical. So in other words, when you make an all acrylic partial, there's actually a chemical bond between the acrylic teeth and the acrylic base. In these, the resin fitting around the teeth, and oftentimes into some diatorics at the laboratory cuts in there, are what holds it in place. So because of that, almost all of these require 5 millimeters of space. So when you're looking at your cases that are severely overclosed, you may not be able to do a flexible, or at least you may not be able to put teeth all the way back. Like you might wind up doing, on this case, a premolar and a molar instead of doing 2 molars. We'll talk about why this might not be the most advisable design anyhow for a flexible, but there's that. And then I have here listed the 2 major materials. Us laboratories are not that different from you guys in that you'll find that each laboratory, both on the fixed and the removable side, has materials that they get the best results with. So some labs are going to have better success with the Valplast, which is a nylon material. It's been around for a long, long time. And some labs are going to be more successful with the Duraflex, which is a polypropylene. Yeah, I was getting a blank there. A polypropylene material. Valplast really can't be repaired. Very difficult because nothing sticks to nylon. Duraflex, there is a way to inject some material to repair it. So, and I feel like of the labs that I know, kind of the nod would go more to the Duraflex, but lots of labs are doing both. Valplast has a milled strategy. There is a organization out there that's making a milled Valplast restoration. So there has been some digital adoption, but not enough to really make a difference. Oh, one other thing, some of the, like, you don't want your patients cleaning these in bleach, it'll destroy them. But some of even the strong denture cleansers can be a little bit much for these. So it's better to just wash them with soapy water. The Valplast tends to be a little more susceptible to chemical damage than Duraflex, but both are, need to be careful with them. This partial, it's a pretty picture, but I like this slide because it probably isn't the best solution for a flexible. Because one of the challenges with a flexible restoration like this is that everything is flexible. This is flexible, this is flexible, this is flexible, not just the clasps. So when your patient bites down on this, it's going to have a little bit of give to it. It's not going to feel real solid. And if your patient has really strong biting force, they may feel the thing actually flexing cross arch. So a case like this, there might be a better way to do this than either the Valplast or the Duraflex. This is what I wanted to tell you guys about. This is, as far as I know, it's the first printed resin that's available. And it's in pre-release right now. So Keystone and Carbon will be releasing this in Q2 for widespread consumption. So don't be surprised if you start seeing a lot of laboratories advertising printed flexible partials. One of the interesting things about this is that it's a composite material. It's a super long chain polymer, but you can put whatever kind of teeth you want in it. Because traditionally for us labs, the challenge with flexible partials was that, again, the teeth weren't bonding. So with this material, the teeth are actually bonded. So let's not push the envelope on day one, but we may be able to get around that 5 millimeter vertical space constraint that we've dealt with in the past. And of course, this makes, for a lot of our laboratories have carbon printers already. So this will make printing flexible partials a big step towards being more available than they've been for a long time. So this is an interesting process, and I don't want to, I like materials and stuff, so I'll tell you a little bit about it, but I don't want to really dig into it. In order to make this material, Carbon makes a lot of other weird things that are not related to dental, like they make Adidas shoes, they make the inserts for the NFL's helmets, different things like that. And so they have a lot of experience with trying to build long chain polymers. And so what they've done with this is it's a two-stage cure. When you normally, for those of you that have done 3D printing, you just put liquid in your little bath and then it prints on the tray with the laser. But with this stuff, it's a two-part like epoxy. So it has a pot life when you put the resin in to print. And then after it's printed, it needs to be cured in a salt tray in a heated oven to finally build out the chain. So it's very, for us laboratories, it's going to be a very different fabrication process than we're used to with printing. But I think this is going to take digital flexibles from being a thing that you hear about every great once in a while in that one lab that does some milling to something that an awful lot of labs are going to be involved in. I'll tell you, right after this class, the carbon booth was swarmed. So anyhow, like I said, this summer, expect to hear more about this product. Combination partials. So this is one of those things that I feel like is a little bit underutilized. Because like that case here, let me switch back here. This case, imagine if this were all metal. A, I can make it smaller. And then B, now all of a sudden it's not flexible. So I get the advantage of the flexible clasps, but the rigidity of the metal as well. So this can be a solution that I think once you start using it, you'll find more and more applications for it. The most challenging part of these is that this clasp, you can't test it until you get to the end of the process. So in other words, this has to be waxed and injected. Right now, the workflow for this is going to be, even if you DLP print the frame, you're going to need to inject the resin. So when you do the try-in, you're not really going to have any retention unless you'd like the lab to add some temporary wrought wire clasps or something like that. So that's really the only drawback to this. But you can see that you get the aesthetics and the comfort from the flexible, and then you get the rigid framework to, prevent the whole thing from flexing. One other thing to keep in mind with this is that, of course, you could add to the metal the injected resin, not so much. I don't know if you guys have had a lot of exposure to some of the advanced milled polymers. There's Altair AKP that was out there for a while, Pectin, Peak, and I don't know how you pronounce it, PAEK, Peak? I don't know. So I apologize for the bad pronunciation. But like, for instance, Altair is very strong, but it's this weird brownish, orangish, greenish color. It doesn't look like natural teeth. And so we wind up trying to put composite over the clasp, and then the composite ships off. It's got the strength, but it just isn't awesome. So this VisiClear material is really the only thing that I know of that has that's a non-metallic option for tooth supported. So we can make rests in this material. So this is also a nylon material. It's a high strength nylon material, and it can be milled. Actually, you can buy pucks of this stuff and mill it. Also inject it. One of the cool things to talk with your laboratories about is that we can also make individual clasps out of this material. So like, let's say you got a Kennedy class 4 and you need a couple clasps on the cuspids. These clear, if you do acres and embed them in the acrylic, you can definitely get a more aesthetic result. If you see these cases in the mouth, they tend to look actually a little bit bluish. So you can see them. They're not perfectly invisible, but they are a really nice solution. Most of the time when you make these, the saddles are going to be traditional acrylic. So, and so of course you could do a quick snap design. You could design this pink resin, white resin, and then milled clear resin and assemble the whole thing. I don't know of anybody who's doing that right now, but this is right now mostly injected, and then this would be processed The nice thing about having the process saddles is that you can reline it or you can repair. This area you cannot repair, so you won't be able to add teeth or anything like that. But it is a really nice restoration. I've seen quite a few of them done. So our labs do quite a few. So when you want a more aesthetic solution for a partial, keep this one in mind. So let's talk a little bit about the workflows for doing partials. The first thing is that we need a really, really, really accurate impression. I think in some ways, taking a physical impression for a partial is going to be one of the most challenging impressions that you take because it has to fit on all the teeth. So all these teeth, your impression has to be as accurate as it would for a crown and bridge case. But then you also need to pick up all the vestibular areas, especially the saddle area, to get a good fit. If you have to pick one, if you're having a hard time getting an impression, do keep in mind that if you're doing a frame type partial, we can put a custom tray on the saddle and you can do a reline impression to pick up a little more detail on the saddle. But these things, most of these partials are very unforgiving. So you need to have PVS, polyether, a very, very accurate impression material. You'll find most of the time for us labs, when we make the models, we don't pour these out of the lab stone that we use for dentures, but most of the time we'll actually do die stone because we need that accuracy too. Now, one of the things you need to look at with your partials for analog is, do I think I can get an accurate bite or am I going to need a bite block? So for instance, if you're doing a class 1 case, you'll probably need a bite block. So you're pretty much going to be stuck with 3 impressions. You'll need to do your impression, your bite try-in, and your delivery. A lot of times, us laboratories like to do frame try-ins for our cases that use a rigid frame because it's easier for you guys to see if the frame fits without all the saddles and stuff on it. But do be talking with your laboratory. Sometimes we tend to be a little bit cavalier with using chairside time, which isn't good. I'm not saying we should do that, but sometimes we don't challenge ourselves to figure out, is there a way we could do this with less appointments? So make sure you kind of think about that and talk with your laboratory about, I think with this case, we could probably do this case in just 3 appointments rather than 4 like we normally would. Most of the time for flexibles, unless there's a bite issue, we normally do those in 2 appointments because there really isn't a frame. The whole thing is the frame. So we'll usually do impression and delivery. So you need to make sure you get a really nice bite. Anything else about this workflow that's important? Don't forget about custom trays. Sometimes the reason that these impressions are so hard to take is because you'll have this area has so much impression material in it because it's a tray designed for teeth that it kind of runs all over the place and you don't get a nice detail. So again, take your time, get that really, really nice impression like you would for a crown and bridge case, and it'll make everything go smoother. Time invested at the front end pays dividends at the back end. But digital. So I think digital is huge for partials. As you guys know, one of the nice things about taking a digital scan is that if there are problems with the scan, you're going to see the file just won't stitch. So you're scanning, all of a sudden it stops clicking, you're looking, you're like, oh man, I'm not picking. So you got to go back up and pick up. So that's really I think it's much easier to get the level of accuracy that you need with an iOS. Sometimes it can be a little bit difficult to capture the soft tissue. If you're using an older scanner, try turning off the AI. For newer scanners, especially if you're scanning, say, class 1 or something that has a large saddle area, or you have to scan the palate, it can be very helpful to use the denture setting to pick up that tissue. Of course, you'll scan the opposing. But here's the cool thing with iOSs that I think is so revolutionary, especially if we pair it with a digital manufacturing process, is that you could technically have only one tooth that touches, and you can take a scan that gives us the perfect bite. So many times when we're looking at the analog process, we have two basic problems. Like, it's hard to get a good enough impression to make sure that the partial is going to fit well, and many times you're bringing the patient in another time just basically to get a bite. And so with the iOS process, you can almost certainly capture that bite every time. And so again, some of us labs got to kind of break out of what we've been thinking about, but iOSs give you the option of doing more and more cases for partials as a 2 appointment. I think, again, communication is the key. There's going to be sometimes that your laboratory is going to say, I can go ahead and make you a partial and go all the way to finish, but if there's any problems, it's going to be so difficult for you to adjust it. Again, you're going to see less adjustments with these cases, of course. Immediates, these can work really well for immediates. It's extracting teeth digitally can be fairly predictable for us. One thing you can help your laboratory with is kind of let them know where you expect the tissue to go when you're after the extraction. So that can be pretty important. So I think for those of you that have iOSs but haven't been using them for partials, I think this can be a way that you can start cutting down on the appointments that you're doing and getting a little more less chair time, more predictable, some better partial workflows. So here's some codes. I'll leave this up for a minute. So these are CDT codes for some of the partial procedures that you're doing in your offices. Probably a lot of you already know this. If you have some that you haven't used regularly, these can be very helpful. I always think it's funny when I first saw CDT codes, of course, as a dental technician, that's what I think of. I think a certified dental technician is like, oh yeah, that's also the nomenclature in the office for the codes that you guys use for tracking and billing your cases. So that's what I have for tonight.